Good morning, everybody. I think in Geneva, for Geneva people, and good afternoon in the Western Pacific region. My name is Sahar Burgess, and I'm a consultant for viral hepatitis at WHO for the Western Pacific region in Manila. And it's my pleasure to be co-chairing this session, looking at the progress and the response of viral hepatitis elimination in the Western Pacific region. It's also my great pleasure to be co-chairing with Professor Ben Cowie. Ben, do you want to say hello and introduce yourself, please?
Yeah, hello, colleagues. I am Ben Cowie, and I'm the director of the WHO Collaborating Centre for Viral Hepatitis here in Melbourne, Australia. And it is a great honour to be co-chairing this session with Sahar, and looking forward to a really fantastic array of speakers and some wonderful Q&A to follow. Back to you, Sahar.
Wonderful. Thank you, Ben. So I'm just going to kick off the session with just a few words, just to set the scene as to sort of the burden of viral hepatitis in the region. As many of you already know, there are about 300 million people living with hepatitis B infection or chronic hepatitis B infections globally, and around 40% of those are among people who live in the Western Pacific region, and almost 20% of the 58 million people that live with chronic hepatitis C infection are also in the region. The region has seen an amazing sort of remarkable progress towards viral hepatitis so far, with the expansion of hepatitis B and C services in the region, particularly through domestic financing and reducing the prices of drugs, the hepatitis B and C drugs, and also in terms of prevention, mother-to-child transmission, particularly through national immunization programs for hepatitis B, vaccination for children. And in fact, we've already met our global target for 2030 to reduce the incidence of hepatitis B as measured by the prevalence of hepatitis B surface antigen to less than 1% among children under the age of 5 years. However, there are still some challenges. There are big gaps in diagnosis and treatment uptake for both hepatitis B and C. And we're still a long way to go, really, to achieve the impact target to reduce the incidence of mortality related to hepatitis B and C infection. There was a great presentation yesterday, actually, from colleagues at the Cancer Council in Australia that looked at the overview of liver incidence, liver cancer incidence and liver disease, cancer-associated mortality. And the Western Pacific region still has the highest incidence of liver cancer globally and the highest liver cancer associated mortality globally. So once again, we still have a long way to go in reaching people and engaging them into diagnosis and treatment. I'd like to now hand over to Leanne Tran for a few more words and remarks. Leanne Tran is from the Peter Doherty Institute. She's a researcher there, as well as a board member at the World Hepatitis Alliance Western Pacific region. Leanne, thanks so much for joining us, and over to you.
Thank you very much, Sarah, and good morning, everyone. I'm talking to you from Geneva today. Yeah, I was hoping for a summer day in Geneva, but actually it's rainy today, so nothing to complain. So I guess, so what I just want to say today is a little bit about WHA and what the regional aspect of hepatitis from our perspective. So my name is Leanne. I'm from Melbourne. I live with hepatitis B like many million people in our region. And currently I serve my second term as the regional board member for the WHA, representing the Western Pacific region. So for anyone who do not know, not anyone I could see here. So WHA, the World Hepatitis Alliance, is an international network of organizations working in over 100 countries towards the goal of eliminating hepatitis by 2030. Our network comprises of, as of today, 315 civil society and community organizations across the world. So together we lead the fight against hepatitis through advocacy, capacity building, and awareness raising. So we are led and governed by people with lived experience in our board, and ensure that people with lived experience of hepatitis are at the heart of everything we do. So in the 37 member states, countries in the WIPO region, we have 35 members in 9 countries, which is not the number that I'm proud of, and would like to make our regional representation better. So I'm calling, if you or your partners are a community organization or civil society with an interest in viral hepatitis and not yet a member, please consider becoming a member of the World Hepatitis Alliance. So please contact me if you have any questions, and we can take it from there, or you can contact the team at the WHA office in London. And I guess, again, thanks, Saha, for your overview of our regional burden and progress of hepatitis. I just want to once again emphasize that our region has the biggest burden in all 6 WHO regions. And sadly, it is not only a health burden, but also the social impact of viral hepatitis to people living with it is so alarming in our region. No region, I can be biased, but it is my personal takeaway after many meetings and things. So, I mean, no region has such cruel discrimination against people living with hepatitis in our region. So many of us here have heard, have worked, have fight, and even experienced that. So in China, in Vietnam, in the Philippines, Australia, and so on. So stigma and discrimination because of hepatitis in our region appears in social relationship, in workplace, in healthcare, and disappointingly in private and government policies as well. So that actually prevents people engage in care and make it a barrier to elimination, like in a bigger picture, on top of like the personal well-being. And this is also the matter of human rights violation. And I'm glad that many of us are working to address it. I want to have more and more people join our effort. And also, as Saha mentioned about the global health sector strategy and our regional plans, I welcome the strategic direction in our regional plan, where engagement with community and civil societies is to be prioritized. So as a voice from the affected community, I committed to be part of the process. And I know that many of my peers are too. And so country and states and all policy and decision makers, please don't forget us when you are making any decisions about us. So by that, I think that's all I wanted to say. So today's session is a part of the World Hepatitis Summit organized by WHO in collaboration with WHA. And thank you very much, the WIPRO region office, and especially Saha for leading this session and building up the session. Thank you.
Wonderful. Thank you so much, Leanne, for that really wonderful introduction into the session. And yeah, stigma and discrimination at the forefront. There's a lot of work to be done in that area for us to get to where we need to get to. So thank you so much. So I would like to now go on to the next section of the session, which will be to have abstract presentations from 3 amazing presenters. And after the abstract presentations, we will have time for a couple of questions. So please do ask questions in the Q&A. Please type them in there and we will get to them at the end of this first block. And any comments as well, please put them into the live Q&A. We'd love to hear from you to really engage in discussion. So without further ado, I'd like to introduce our first presenter, Dr. Jackie Richmond. She is the National Workforce Development and Health Service Delivery Project Manager at the Burnett Institute for Eliminate C. And she's from Australia, and she'll be presenting on learnings from a national implementation. And I'll take it this is in Australia as well. So over to you, Jackie, and thank you.
Hi, my name is Jackie Richmond, and on behalf of my colleagues at the Burnett Institute in Melbourne, Australia, thank you for the opportunity to present today on learnings from a national implementation project, Eliminate Hepatitis C Australia, or as we call it, EC Australia. I'd like to begin by acknowledging the traditional custodians of the land from which I'm presenting from today, the Wurundjeri people of the Kulin Nation, and I pay my respects to their elders past, present and emerging. EC Australia was funded by the Paul Ramsay Foundation, which is a philanthropic organisation, to develop a national coordinated response to eliminate hepatitis C as a public health threat in Australia by 2030. Specifically, we did this by developing a national collaborative framework and a coordinated response so that we were all on the same path trying to reach our goals. EC Australia has 6 components. I'm going to focus on workforce development and health service delivery today, but there are 5 other components, and details about these components can be found on the website below. We started EC Australia by conducting a national stakeholder engagement across the country. Each of the Australian jurisdictions has a governance committee responsible for hepatitis B and C elimination. So this is where we started. And these committees were central to the prioritisation projects for the workforce development, which I'll talk about in a moment. We also met with other key stakeholders, and all the information we gathered during this national consultation really informed the implementation of EC Australia. Workforce development and health service delivery was allocated 4.7 million Australian dollars. And each of the Australian jurisdictions was allocated a budget dependent upon their size, the population living with hepatitis C, and previous or current financial investment in elimination activities. So there was a range from $100,000 to $840,000 over the 3-year period. Those governance committees in the jurisdictions were absolutely critical to identifying and prioritising local activities and funding opportunities that could aim to increase testing and treatment of people living with and at risk of hepatitis C in their jurisdiction. Proposals developed by these committees were presented in a forum in August of 2020. The proposals were assessed according to the guiding principles of workforce development and health service delivery, and they were the scale up, the potential for the project to prioritise hepatitis C care, using evidence-based approaches that avoided duplication, trying to address equity and responding to data, and enhancing sustainability. Essentially, the funding was intended to be catalytic and to stimulate activity and to stimulate the framework of collaboration. In the end, 21 projects were funded, and they were grouped into 4 themes across workforce development, models of care, incentives for people at risk of hepatitis C, and linkage to care using passive surveillance systems. I just have to say now that obviously these 21 projects and our partners have worked extraordinarily hard over 2.5 years during a global pandemic, and we never anticipated that this would be the conditions in which they would be working, but they have adjusted and adapted and have still delivered in so many ways, and we have so many learnings to share. The team at EC Australia, we really provided not only project support, but technical support. And that is, I guess, based on the strengths of the Burnett Institute. So we certainly provided that implementation support around contracts, but technical support, which I'll talk about more in a moment with regards to monitoring and evaluation. But we developed and fostered relationships. We connected partners, organisations, people with shared interests across the country. And certainly we're in the process of helping with dissemination at the moment. Our role in monitoring and evaluation was very hands-on. So we created standardised evaluation frameworks for each of the partners and then supported them to develop a program logic and evaluation plans. Projects reported to us every 6 months, but we really tried to reduce the burden of reporting. So often we would have meetings and we would take notes based on the discussion to try and reduce that burden of writing things down. But that regular contact allowed us to track and monitor the impact as well as the learnings that have occurred across the length of the project. We've provided technical support, helped with designing databases, data collection and analysis, applying for ethics and funding applications, drafting abstracts, and also supporting in the development of manuscripts. Overall, what we've tried to do is really build the capacity of these 21 organisations that we've been working with, develop a community of practice so that people can come together and share the learnings about implementation of the projects, but also the challenges associated with trying to do that work during a pandemic. And we also built their capacity, or attempted to build a capacity around monitoring and evaluation through a webinar series. So where we are at the moment, we have 14 projects that have finished and they've reported back to us. 7 projects are finishing and will report by October of this year. So our work at the moment is really focused on the evaluation and of the entire program of workforce development and health service delivery. Dissemination is also really important, and we're working with partners to develop infographics such as this one. So this is an infographic on an incentives project that was run in Cairns, which is in far north Queensland. And I believe there are many of these projects around Cairns, telling not only consumers who were involved in the project, but people who referred into the project and other key stakeholders about the success of this incentives project. So what have we learnt? Certainly nurse-led models of care working in partnership with peers, so people with lived experience of injecting drug use and or hepatitis C infection. When that partnership work in an outreach setting, such as a Netherlands syringe program, homelessness service, mental health service, or going to wherever the people are, not expecting them to come to us, but going to where they are already accessing services, are absolutely critical. Most of our models of care are nurse-led, and some of them do also work with peers. So the role of the peer in engaging people at risk, being able to introduce people at risk to a trusted service in a nurse-led service, has been really valuable in terms of engaging people who haven't previously had access to hepatitis C testing and treatment. Incentives have also been identified by both the nurses and the peers as critical to engagement of people at risk. We've had a couple of point of care testing projects, and they have been able to test high numbers of people within priority settings and have been really clearly very acceptable to consumers. Community corrections has been identified as a new priority setting. So this is either capturing people outside when they don't go to jail or go to prison, but they go and serve community corrections orders and have regular reporting, or supporting people upon release from jail. So one of the projects has set up hepatitis C testing and treatment clinics within community corrections services and have had extraordinary success, have found a high prevalence of hepatitis C RNA positivity and people who haven't previously had access to testing and treatment. A number of the projects that we funded have also conducted clinical audits to identify people at risk or people who need further follow-up for hepatitis C in primary care settings. This has been really affected by the pandemic, staff shortages and the stress and increased workload on primary care in Australia during the pandemic and also during the rollout of the vaccination program has been considerable. And we feel that there is a real opportunity for the patient management systems to be automated so that they don't have to be human dependent. We need to focus our activities on implementing the audits, so conducting the recalls and bringing people in. And that is very challenging when there's no funding necessarily attached to ensure that that work gets done. A number of the linkage to care projects have identified that there are significant numbers of people being tested for hepatitis C within the tertiary hospital system, and this is across departments. So we see this as a real opportunity for centralising referrals and linkage to care. What we've learned is that EC is a transferable, it's very efficient, and it's a scalable model. Stakeholder engagement has underpinned the entire partnership, and relying on the local governance committees and experts and stakeholders to identify funding priorities has been, I think, one of the greatest successes. We have come in as the EC Australia team and provided monitoring and evaluation support and created a network that's allowed our partners to share formal and informal learnings. Project sustainability is something we've been really mindful of. We were intending always to be catalytic and hoped that sustainability would follow with when the projects are able to provide monitoring and evaluation data that shows their outcomes. To date, 4 of the projects have received ongoing funding, and I know there are another couple of projects that are also seeking additional funds to continue the project. EC Australia took a really unique approach by working collaboratively with partners to generate and share evidence about which programs and approaches worked and why. And in doing so, has established a framework, I think, for working collaboratively across the country. I really want to acknowledge the partners that we've worked with in the workforce development component of EC Australia. They have gone above and beyond, adapted and changed and just done the most incredible job over the past 2.5 years. And also I'd like to thank our funder, Paul Ramsay Foundation, for their flexibility, understanding, and most importantly, encouraging us to focus on learnings and reflections as really important outcomes that can drive us towards elimination. Thank you.
Wonderful. Thank you so much, Jackie, for this really wonderful work that's happening in Australia. I really loved the community of practice. I think this is a really nice way to look at how we should be actually working together as a community of practice. I really like that. And another thing is obviously around this, we're talking lots about catalytic funding, catalytic projects, really to drive and finance projects to provide tools for countries to be able to scale up and simplify and decentralize services and models of care. So thank you so much for that. That's really fantastic work. I would like to now move on to the next presentation. I'd like to introduce Dr. Thomas Russell. Thomas is an internal medicine specialist at Toongaru Central Hospital in Kiribati, and he will be presenting on the response to the high prevalence of viral hepatitis in Kiribati. Thank you so much for joining us, and over to you.
Kumna Maori and greetings, everyone. My name is Thomas Russell, and I'm a physician from Kiribati. I'm grateful for this opportunity to share an overview of Kiribati's treatment program. The topic of this talk is the response to the high prevalence of viral hepatitis in Kiribati. Thank you. In this presentation, I will give a quick description of Kiribati. I will provide context of its health sector. I will give focus to its viral hepatitis situation and the response to it, with the establishment of the first treatment program in a Pacific Island country. I will share the program's activities, current progress, challenges, and way forward. The Republic of Kiribati is an equatorial, low-middle income, large ocean state with limited land area in the Central Pacific Ocean. It has 32 coral atolls and 1 raised coral island, scattered over an ocean expanse so large the country is in all 4 cardinal hemispheres. It has a population of almost 120,000, with the majority residing in the capital island of South Tarawa. With few natural resources, national income is through sales of fish license and overseas employment remittance. The country's health status reflects its socio-economic conditions, with limitations across its various sectors. It has one of the highest under 5 mortality rates in the region. It has an established immunization program, with the hepatitis birth dose vaccination rates reported as 91% in 2020. There is only 1 national hospital located on South Tarawa. There are 3 district hospitals manned by doctors and nurses, and 112 lower-level health facilities managed by medical assistants and public health nurses. There are no doctors, lab, or imaging services available at these lower-level health facilities. Although medical services are free, they are limited. The graph shows how the national burden of disease has shifted in the last 30 years, with NCDs currently being most prominent. TB and leprosy are the commonest communicable diseases. There is a shortage of healthcare workers, with only 5 doctors per 10,000 people, and even fewer medical assistants. Outer island healthcare is provided by medical assistants, public health nurses, nurse aides, and volunteers. Kiribati's remoteness and border closures allowed it to defer the arrival of COVID-19 for the first 2 years of the pandemic. However, this has adversely disrupted its medical supply chain, as well as delayed overseas medical referrals for patients requiring life-saving intervention. Chronic shortages in drugs, medical equipment, and lab tests have been exacerbated by the pandemic as well. Nationwide vaccination campaigns continue with the use of AstraZeneca and Sinopharm vaccines. Viral hepatitis B and D are highly endemic in Kiribati. There have been no cases of hepatitis C reported. Childhood vaccination was gradually introduced in 1994 and is given at birth, 6, 10, and 14 weeks of life. There was no treatment available for chronic hepatitis B prior to 2018. Last year, the majority of chronic hepatitis B related deaths were among patients younger than 50 years of age. Antenatal mothers booked in the outer islands are not routinely screened for hepatitis B, and there are no interventional endoscopy services in Kiribati. As a response, partnerships were forged between the Ministry of Health, DFAT, WHO, Hep B Free, Vigil, and Gilead to establish Kiribati's hepatitis program, HOPE, in 2018. It is a free-for-service program. It is managed by a program coordinator. Clinics are conducted by a nurse and medical registrars. Outer island healthcare workers perform vital roles for the expansion of the program to their remote communities, and program activities are supported by paramedical staff, the Steering Hepatitis Task Force Committee, as well as external specialists from Hep B Free who provide technical assistance and training. The program's goals are similar with the general goals of a treatment program, which many of you would be familiar with. The last column of the table shows the flow of activity afforded to antenatal and non-antenatal cases referred to clinic. The numerous program activities are conducted by local healthcare workers, which may be similar and familiar to other treatment programs. Weekly clinics at the National Hospital are supplemented by video teleconference between clinician and patients. Established outer island programs have scheduled clinics with mentoring provided virtually. There is an ongoing national campaign to screen and vaccinate all healthcare workers. Currently, more than 80% have been screened and more than 92% have received their first dose. Annually planned outreach, outer island outreach, is an opportunity for training, screening, vaccination, and linkage of healthcare workers and patients alike. Most cases of chronic hepatitis B in Kiribati are within the younger population. Shown here is data from last year's report on cases registered to the National Hospital. The first table and graph, summarizing the initial 3 years, shows that there is a similar gender distribution of registered cases. Almost a quarter of patients are lost to follow-up or discontinue their treatment, and that the majority of deaths among registered cases are male. The second graph highlights the burden of disease to be among those in their productive years. Almost 70% of registered cases are between 20 to 40 years of age. The predominant cohort of patients would have been those who missed the introduction of hepatitis vaccination to the country. With this dashboard, one can appreciate the remoteness of the islands of Kiribati and the logistical challenge it presents. Illustrated here is the program's current reach and the remaining islands that it has yet to fully access. This year, additional treatment programs have been established in 3 lower-level health facilities indicated in gray and 2 district hospitals that are colored blue. A test and treat approach is carried out for adult and antenatal patients living in outer islands. To date, there have been more than 33,000 surface antigen tests performed, more than 1,500 patients linked to care, more than 150 antenatal mothers, and more than 300 patients started on treatment. The program has many challenges, some of which may be familiar with other national programs. For instance, internet access is expensive and sparse. Healthcare worker training and mentoring is difficult to sustain virtually. Limited in-country resources hamper the ability to provide standard care. Lack of a central database complicates data management and renders the program inefficient. Poor reliability of domestic transportation adds an additional challenge for health service delivery. The concerning prevalence of co-infection places the potential to manage more severe disease, and overcoming traditional beliefs and personal perceptions of hepatitis B is a formidable barrier to treatment. To address these challenges and barriers, there are several short-term plans that the program will work towards, such as the endorsement and implementation of its National Hepatitis Action Plan, to find ways to increase telecommunication access to outer island healthcare workers, to pursue healthcare worker training opportunities for procedures such as imaging and endoscopy, to seek affordable supplies of drugs such as octreotide and tenofovir alafenamide for patients living remotely, to explore opportunities to improve general lab services and point of care testing, including access to viral load testing, to establish a health information database accessible to remote health facilities, to resume work with the external specialists who will travel to Kiribati later this year to perform clinical outreach, to continue to screen for hepatitis D and provide consistent information to strike a healthy balance between traditional perceptions and clinical advice on hepatitis treatment. In a relatively short period of time, much has been achieved by the program with plenty of support along the way. Yet the team collectively recognizes that there is still much more to be done, and it will continue to align its efforts towards achieving global goals for the elimination of hepatitis B. Kampasindapa, and thank you very much for your time.
Wonderful. Thank you so much, Dr. Thomas. That was an excellent overview of the activities and the challenges around viral hepatitis response in Kiribati. So I'm really impressed to see the healthcare worker mass screening and also vaccination. And I can see there's already a question coming up for you. So we'll ask the question at the end of the abstract session. So I'll save that for later. I would like to now introduce our next presenter, Mr. Chris Munoz from the Yellow Warrior Society of the Philippines. He is the past president and now advisor to that society, and he'll be presenting on bridging the gap. Thank you so much, Chris.
Good morning, good afternoon, and good evening. I'm Chris Munoz from the Yellow Warrior Society Philippines, and I'm here to present what we have been doing in the past few years. So there are two types of healthcare services wherein our members can opt to go. First is the private, and the other one is the public. If one goes to the private hospitals or clinics, then there is always out-of-pocket expenditure. Second, if they opt to go to the public, there's always a challenge of long lines, cut-off time, availability of doctors, rooms, diagnostics, and the likes. So how do we bridge the gap when it comes to our members who opt to go to the private facilities? We basically connect them on their particular needs from vaccination, diagnostics, and medicines. Hepatitis B immunoglobulin is not free in the Philippines, and there are hepatitis B positive mothers that are looking for HB to be given to their babies at birth. The challenge, though, is the availability and price that has almost doubled since 5 years ago. We were able to partner with a distributor, and our members got it at a cheaper price. With these partnerships, we were able also to cater cheaper hepatitis B vaccine to those who miss their 4 doses of Hep B vaccine that's given free by the government. When it comes to diagnostics, which is one of the barriers to treatment, because of its cost, we were able to partner with laboratories and hospitals to be able to get a discount for our members. And of course, partnering with doctors is also very vital, so that members can get free or discounted consultation with them. Lastly, we also partnered with different pharmaceuticals so that our members can get their medicine at a discounted price. So Yellow Warriors facilitates the need of members, ensure patient confidentiality, and protects patients from wrong information, especially when it comes to medicine. But what we are more focused on are the needs of those who want to access the government program, which I believe is sustainable and complies with the SDGs. Last 2019, Philippines has started to implement its hepatitis B in some pilot sites. Some of these pilot sites also give hepatitis C testing and treatment for free. These pilot sites will provide services starting in the primary level, and patients will be referred in other facilities as needed. But because of these models, the general public will have access to early detection and treatment, and most importantly, these services are given for free. Just like any newly rolled out programs, there are gaps on the ground, and it is where Yellow Wire Society Philippines plays its role in bridging the gaps in the system. So right now, there are 3 access sites to treatment. First is the end referral facilities or hospitals that are under the Department of Health. Any patient can access this hospital, and it is a one-stop shop hospital wherein they can get screened, avail of diagnostic tests, and treated if needed. The gap here that only a few knows that these hospitals offer this kind of service and how to access it. So what we do is to inform our members and urge them to avail of the service. To be able to explain the process to our members, one of our officers went to the facility to experience what it is like to undergo their process. Even if it is a one-stop shop, a patient cannot finish the whole process in one day because there are limitations such as availability of the doctor, long lines, or long queues for each step since the facility also caters to other kinds of health issues. If one were to go to the facility without any idea on the access, then there is a possibility that he or she would not even reach step 2. To be able to improve patient experience, we partnered with those handling the program, and it really brings the importance of both parties discussing on the common goal of bringing the best service to the patients. We were able to clarify on how patients can access the system with more ease and comfort. We were also able to help them out with their medicines since they ran out of stocks and they have patients waiting for their medicines. Immediately, we reached out to one of our partners that is a member of our technical working group, and we were allowed to facilitate the delivery of their medicines. Our partnership didn't end on that day, and instead, we started another collaboration on how to raise awareness to other medical practitioners that is being handled by the facility or the doctors. This is just one facility, and we are targeting, if possible, to get in touch with all facilities. Another access are the HACT or the HIV/AIDS core team. This facility dispenses Hep B medicines in case a patient already has prescription. Again, through collaboration, we were able to bridge the gap by facilitating the availability of meds in one of the HACT offices, and we were able to pass on to them more than 100 new patients and still counting. Another upside was that they were also able to get HIV patients through our partnership, and even during the pandemic, they did not stop catering to patients. There are more than 100 HACT offices nationwide, and we will be getting in touch with them soon. The third access are those who reside in cities who already implemented the program, like Bataan City. Training and capacity building was given to all of us with the technical support of the WHO and the Hepatology Society of the Philippines. Region 3 was the first to implement the program, and with close collaboration, we were able to raise awareness and concerns of the patients. Just like in other cities who are implementing the program, there is a possibility of patients getting lost in the system, and we help them navigate it. So you can see in the slide that patients are required to transfer from one health facility to another. And in between, some patients get lost or drop out of the system. For those who are really determined to go through the process, they would message us or comment in our group. And that is the time we can check the gaps and help them get clarification or assistance, since we do work closely with people in the facility. One of the struggles is the diagnostics. It is not free, and patients have to go to another office, which we call Malasakit Center, to be able to get the free or discounted laboratory test, depending on the assessment of the social worker. This requires another set of requirements, and if a patient was not able to get approval, then it has to be an out-of-pocket expense. So we hope in the future that the program would be fully funded, so patients would not need to line up just to be able to get free diagnostic tests. Our mapping of facilities is a work in progress, and we hope that service delivery networks would expand in the whole country to give service to patients living with viral hepatitis. This also goes to show that patient organizations, civil society, and the public, when working hand in hand, collaborating, supporting, partnering with government institutions, can make the systems more efficient and responsive in the needs of the society. Thank you very much.
Wow, thank you so much for that, Chris. What an amazing presentation and illustration, demonstration, how important it is to have, partnerships, collaborations across civil society, the public, clinicians, and this is exactly what we need to go forward. And congratulations on the amazing work that you do to bridge those gaps. I think that's a perfect title for your presentation, honestly. So thank you so much, and couldn't agree more around, you shouldn't have a lineup of people trying to access diagnostics and service and treatment, and affordability is still a huge problem, in our region and obviously globally. So with that, there's a lot to do with UHC, universal health coverage, that is on sort of the agenda for the global health sector strategy going forward. So thank you so much once again. So this is a fantastic start to our session. Thank you so much. We do have some questions. Ben, did you want to maybe, I know you've got probably a couple already that you wanted to share and ask our colleagues.
Absolutely. Thank you so much, Sahar. And I might follow on with the first question for Chris, please. So, Chris, Leanne, in her introduction, talked about the importance of having affected community at the centre of the response and leading the response. And you've talked about creating partnerships. What is going to be required for us to ensure that governance is in place and effective, and that civil society, and particularly people living with viral hepatitis, are helping to lead the response in the Western Pacific region?
Well, I think most importantly is that patient groups should be included in the technical working groups of the government, because first it is where we start formulating policies. And of course, when you roll down that program down, only the patients can tell you if or give you feedback on how the program goes. So that is how we do. We start from top, and then we give feedback at the bottom to make the service more efficient.
Okay, thank you. It's such an important aspect, isn't it, to ensure that civil society are contributing to all aspects of the response. I wonder if I could turn to Jackie now. Jackie, we have a question from On, who's asked, first of all, said thanks for the great presentation, and then has asked, could you share more about some of the incentive programs that were coordinated through EC Australia? And if I could add something to that, how would you see those working in low and middle income countries?
Thanks, Ben. I'll take the first part. So we funded 3 incentive programs. They were quite different models. One was we gave money directly to a community health service. It was a small amount of money. They had, that was the one in Cairns in far north Queensland. They knew exactly who they wanted to test and treat and engage. So they needed that incentive to help bring people into the service. In actual fact, what we found in that was it brought new people to the service, people who had never been tested in that system before. The second incentive project was, once again, not a huge amount of money that was given to a university that then had expressions of interest, and money was then distributed out to 7 different organisations, and those were chosen through an expression of interest process. So each of those 7 organisations then subsequently delivered quite different incentive models. And then the third was, it was run through needle and syringe programs, and we've got, once again, a large number of needle and syringe programs in one of the Australian jurisdictions that has linked it very closely with a testing and treatment campaign. So lots of learnings, and then along the way, nurse-led models of care have also been able to pick up money for incentives. It's an excellent engagement tool, bringing people into the service, particularly for testing and for maintaining engagement through the care cascade. And there's many different forms of incentives, as everybody will know. It's not just financial incentives, but certainly we've had lots of projects that have used food, clothing, and other ways of reimbursing people for their time and their engagement in this care. Ben, I have very limited experience of working in low and middle income countries, so I'm very, very aware that I'm probably not the best person to ask. But I do think what we've shown with the incentives is that there's varying ways, and this is, it's problematic from an evaluation perspective because we've got different amounts being given at different times, and certainly, as I said, different forms of incentives that are being given. But certainly from an Australian perspective, I think where we are in terms of our pathway and our progress to elimination, I think incentives in some way, shape or form need to be incorporated now into most models of care as an engagement tool.
Thanks, Jackie. And a couple of very quick questions, if I may, to Dr. Thomas. Great presentation. 2 questions for you briefly, Dr. Thomas, before Sahar gets angry at me. The first is, Dan Saltman has asked, what strategies are being used to ensure continuity of medication for patients being treated for chronic hepatitis B? I think this is particularly relevant to some countries, particularly with resource constraints and where distribution models may be challenged, such as Pacific Island countries and territories. So can you answer that question for us, please, from a Kiribati perspective?
Thank you for the question, and thank you, Ben. I think that's a very relevant question right now. We do have issues with continuity and with limited supply chain, which is very much challenged in these times with COVID. To give you a broad, a very specific example, is that at this present moment, we have about 600 patients on treatment with only less than 200 bottles of TDF remaining in the country, with no supply ready to come to the country. So that's a real sobering reality that we often face in our area remotely in the middle of the Pacific. And so we are sort of trying to find our ways around it. One of the issues that we like to address is forecasting. And so we'd like to implement a electronic medical record system that sort of links with the pharmacy's M-supply that they use. And if we're able to sort of link these data and identify new cases, identify new patients on treatment, we'll be better able to forecast and have an idea of when to submit a purchase order to our suppliers. But it's a big challenge.
Thank you. Yeah. And just very, very quickly, a couple of related questions from Pauline, our colleague who is a long-standing friend of the Western Pacific region. Even now she's decamped one region across. And that question is regarding the age group infected in Kiribati from your data appears to be those aged 20 to 40, less in those aged over 50. Would you like to comment on those data? And a related question, do you see greater mortality than expected in that 20 to 40 age group? And then I'll hand back to Sahar, I promise.
All right, thank you. Yes, it is an interesting aspect of the data. So that data was initially collected from the main hospital when the program was first initiated. And we did notice that the age group that had missed the vaccination, the introduction of the birth dose vaccine in the mid-90s, was particularly only the 20 to 40. It is, for me, I'm not so sure. We don't have robust data to explain why the older age group does not appear to have. One observation might be they're not accessing the clinics well enough as those in the 20 to 40 age group. Another would be possibly early mortality, and that links to the second part of the question where we do on observation and in the clinics and the hospitals, we do see more cases in the 20 to 40 range coming in for decompensated liver disease, and a lot of them are co-infected, about 42% of those who are positive. And we've seen, personally, I've seen a lot of in their 40s developing hepatomas, which we suspect to be HCC, and we do lose a lot of them. And yeah, so I hope that answers the question.
Yeah, it's a complicated issue. Thank you so much, all presenters in the first session. Back to you, Sahar.
Wonderful, thank you so much. I feel like we're on a roll, so I'm going to continue with introducing our presenters. Thanks, Ben. So I'd like to now invite Dr. Wang Ailing from the National Center for Women and Children's Health, China CDC. Thank you so much for joining us today. It's a pleasure to have you with us. Dr. Ailing will be presenting on the progress of triple elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B in China. Over to you, Dr. Ailing. Thank you.
Good morning and afternoon, everybody. It's my great honor to have a chance to give the introduction on elimination mother-to-child transmission of HIV, syphilis, and hepatitis B in China. Thanks so much for WHO intervention. As we know, China has higher disease burden on hepatitis B. There are estimated data in 2008. At that time, we estimate how many infections on the risk of MTCT of China, HIV, syphilis, and hepatitis B. So from 2010, based on the PMTCT of HIV network, we started to the integrated syphilis and hepatitis B MTCT prevention service to existing HIV prevention system. For these years, we always follow 4 strategies to carry out our PMTCT program. From 2010, the financial support was 800 million per year RMB. The areas covered 1/3 of countries in China. From 2015, the program extended to the whole country. The financial support increased to the 1.4 million yuan per year and continue to now. From 2017, we started the pilots for elimination of mother-to-child transmission program in Zhejiang, Yunnan, Guangdong, and Beijing, supported by UNICEF. And now we have more experience and to start to validation for EMTCT. In the implementation plan of the program for the development of women and children in China 2021 to 2013, we just published by government on April this year. It's the list main priorities of mother and children's health in China. There are 2 aspects of eliminations. One is MTCT of HIV, syphilis, and hepatitis B. The other one is cervical cancer. So we will pay more attention to the EMTCT in China. The second strategy is providing integrated service and enhanced service quality. At the beginning of PMTCT program, we implemented all related service into routine maternal and children health service. Take mother-to-child transmission of HIV as an example. The main intervention is testing and counseling, ARV drugs, safe delivery, and infant feeding. The intervention point is also reflected in the integration of 3 mother-to-child transmission disease, from HIV to syphilis and hepatitis B. We also in the similar mode of the service. For all pregnant women could get the routine service. They also get different services from each woman depending on their infection. With HIV, they can go to this round. With syphilis, this round and the service. And for the hepatitis B, is the positive. They can get HBIG and follow-up. They get additional service like pregnancy with anemia. We think we integrated service could reduce the stigma and discrimination. We also have a data collection system. From this system, we not only could get the data of epidemic of infection of pregnant women and their infants, but also we could identify the problems and the weakness. With the data triangulation, we could now do several activities to enhance the quality of the service, such as infection disease report system, annual report of maternal and children's system, EPI data collection system, and other related data. Another point of integration was that we used the laboratory. We used the laboratory and the quality control network that existing at the time for HIV, syphilis, and hepatitis B to do maternal testing. For the beginning, we spend more attention on cooperation resource rather than building new systems, which save a lot of time and financial support. For more than the decade of experience, we have exposed attempted to coordinate the work of several systems of departments, as well as other precedents that require the different systems to work together. So we think we have some experience for this network and for work together, how to work together for the different tasks. The third point is strategies is carry out extensive social mobilization and prevent multi-section cooperation for pregnant women and their infants. There are 3 kinds of organization have direct relation: MCH hospital, general hospitals, and the disease control center. They also have a relationship with their community. All this happen in the society, and several sections improved the implementation of intervention of PMTCT. For example, civil affairs department, education section, and so on. So we can work together now. The last point, strategy is paying attention to the key barriers and the bottlenecks and prevent equality. At the beginning of the program, we paid more attention on the mode summary, team capacity, and the service coverage. And these years, these services are implemented. We are paying more attention to the key barriers and the bottlenecks. We have different priorities every year. For this 2 years, we focus on assessment of EMTCT of hepatitis B, and the community participant. This is our priority of this year. For more details, there are more main activities of EMTCT prevention from 2016. In 2016, we did gap analysis on EMTCT in China. The gap analysis done on national level and provincial level. In 2017, guidelines for launching pilot areas and the evaluation on the effects of PMTCT of hepatitis B in China. To know result intervention of MTCT rates of hepatitis B. In 2018, one main work is training on anti-stigma discrimination in hospital. We invited the experts from Thailand to help us. In 2019, we invited the domestic and foreign experts join site supervision. We summarized the experience and the EMTCT program and expand to the whole country. So in China, we went through a pilot phase, and during which we located and prevented our elimination strategies. From this year, we will start the validation on provincial level. Compared with WHO targets, we still have some indicators have not achieved. To main objective of EMTCT, we will pay attention on improve the weak points. There are 4 main activities. One is giving different guidelines to different category of areas. For Liangshan, we will focus on the capacity building. For Guangdong, we will focus on the migrants, pregnant women. For young people, we will focus on the prevention infection and avoided and unwanted pregnancies. The second point is improving community participation. From 2017, we try our best to involve the community to join into our PMTCT activities. We also applied for a special fund to support NGOs to participate in our program. In recent years, the situation is getting better. Strengthen supervision and quality control and assessment progress and effectiveness successfully will be 2 priority areas that we will deal with. From next month, we will publish our action plan in China, and then we can choose one by one to prevention level to validation. The goal and framework of EMTCT and the validation tools of WHO very clear. By elimination the assessment, we want to raise awareness of MTCT and improve the quality of our service so as to achieve the ultimate goals of keep children away from HIV, syphilis, and hepatitis B. So thank you. So thanks again for WHO. We also look forward to get information and experience from other countries. It's really a great section. Thanks.
Thank you so much, Dr. Aileen. That was a wonderful overview of such a comprehensive package type to response to the PMTCT in China. Thank you so much for that. And there's a lot to learn from the leadership of your program. This is pretty amazing. And I liked how you, with the challenges, you've already got so much happening in terms of addressing those challenges going forward. Thank you so much for that. We will go on to the next presentation now. I would like to now invite Dr. Mohammad Radzi. Dr. Mohammad Radzi is a senior consultant gastroenterologist and head of the Service for Internal Medicine at the Ministry of Health, Malaysia. And he will be presenting on Malaysia's journey to HCV elimination from compulsory licensing to treatment decentralization. Thanks so much for joining us, and please, over to you.
Thank you very much. I hope you can you see my slide?
We can, thank you.
Okay. What I'll do is that I will try to share our experience, the Malaysian journey for the hepatitis C elimination, focusing mainly on the compulsory licensing, and its strategy will be the decentralization. Okay, there are a few key milestones in the Hep CV agenda in Malaysia. I think the 2017 is the year whereby we have obtained the compulsory licensing, which is very, very important and very, very crucial in the eliminations for hepatitis C in Malaysia, because by the compulsory licensing, we are made available to have the generic medicines to be available at the affordable price, because for some reason, I think before the compulsory licensing, Malaysia, which happened to be in the upper middle income country, has to come up with the original medication in order to buy the DAA, which is almost impossible to bear the cost for that. So with that, with the compulsory licensing, we managed to bring in our sofosbuvir, and then we start our treatment with the soft and daclazine. And then we all know that having an affordable DAA is the key steps in terms of the towards the eliminations for the hepatitis C. Sorry, I was trying to find the right word. Okay, so with that, knowing the fact also that in other countries, like in other countries whereby majority of our patients are drug user, IVDU, so a majority of them will be in the community. So one of the key effort, the one that we have done so far, will be the decentralizing our test and treatment to the community in order to provide the access, especially to our PWID in the community. So we have the advantage, i.e. that what we call this the primary healthcare center, which is located throughout the country. There are lots and lots of them, including also some of the hospital which provide this test and treatment for the hepatitis C using our soft and DACLA. That have been happening until that 2020, even though during the COVID period, I think the strategy of decentralization, providing the treatment of the hepatitis C to our clients has been going on quite well. In fact, even during COVID, I think we still managed to roll out about 4,000 and over the DAA to our patients. Then we realized from the 2022 onward that we start to feel that while we are almost probably treating all those patients who have been linked to our healthcare center. So I think from 2022, our strategy probably changed slightly. We're trying to go beyond the low-hanging fruits. I mean, trying to reach out those people who may not be linked for some reason to our healthcare system. So these are the people, for example, like people who inject drugs. They are, for some reason, still out there in the community. They just refuse to come in. So these are the people that we need to focus now on. And also people who are living in the correctional setting, for example, even prisons and also community correctional setting. And also, I think this year, we also have started engagement treating the refugee by working with our NGOs. So this graph illustrates quite clearly after the compulsory licensing, the uptake for the treatments has been increased tremendously after the compulsory licensing. And I would like to emphasize again, I mean, the importance of getting the first key step, I think, because I realized that many of the countries, even in this region, the cost of the DAA is still high. I mean, it's not within the affordable range still. So whatever it takes, I think the first thing that we need to do is to make it affordable. So in whatever means that we can do. And Malaysia have shown that by getting the compulsory licensing, I think we have rolled out the treatment at a very high rate at the moment. So a bit of so far the achievement that we have made by using SOF and DAC. These are two generic medications that we have been using so far. While the SVR rate has been very good. I mean, this is very encouraging, and the overall SVR rate so far is about 95%. This is from the 16 hospitals that we have done at the initial stage of the treatment, regardless of their serologic status, genotypes, whether they use ribavirin or not, or whether they are having co-infections or history of intravenous usage. So this is a very good drug so far. I think the main reasons why our decentralization is working very well, and hepatitis C treatment just came in quite nicely into this program because of our well-established public health systems, which is, I mean, it is located almost every corner of in our country, whereby people will have an access. I mean, nobody is denied to have an access for the healthcare, regardless of their ability to pay. So I think this is probably one of the key factor which catalyze the treatment for the decentralizations. And the other factor is that also because Malaysia has the privilege of providing a free treatment as well as the free lab tests to all our patients. Okay, I'm just going to share with you very briefly our framework of how did we treat hepatitis C in Malaysia by using the decentralization model in Malaysia. So we use the screening with using the rapid test kit, which is easily available, and also they are easy to use. And the next step is for those who are positive using the RDT, there will be confirmations using RNA, as well as some lab will use antigens. And the cost for the lab has come down tremendously. I mean, we are talking about probably in the regions of about $15 to $20 for the confirmations of the viremia. And then the next step will be the cirrhosis status assessment by using the non-invasive marker, APRI as well as the FIT4. So only for those who are decompensated will be referred to the hospital with a specialist. So the patient will be treated with a soft DAC, and then subsequently, I think the next evaluation will be the SVR at the week 12. And majority of the patients we have illustrated earlier, they are cured, and those who are not cured, they will be subjected to the second line treatment. And what is available at the moment in our country will be the software. So a bit of the choices that we have so far after we have ended our compulsory licensing. Sometimes I can't remember exactly, probably about a year or two ago. But now we have also embarking on the voluntary licensing, and the introductions of compulsory licensing actually leads to the very competitive price for the voluntary license coming in. So now we have a couple of other drugs as well as soft rabidosway, soft valve, and also soft dacla, which they're all available in our country. Okay, as I mentioned just now, I think we have come up the first stage, i.e. that easily to treat the patients who are already linked to our healthcare system. But now I think we have to go beyond that, go beyond those are the low-hanging fruits clients. But who are the people that we have to go beyond it? These are the people which I've listed here. These are the people who inject drug, who are somehow, they are under the opioid replacement therapy, but somehow or other they are still out there, but they just simply refuse to get treated for hepatitis C. And quite a number, proportions of them also, the so-called the unreached people who inject drug. These are the so-called the alternative substance abusers. And in our country, there's what we call kratom. It's one of the most popular recreational drug that's been used. Fishermen and also some of the Iceland residents. A bit also from the MSM, the sex worker, and also the refugees. So these are the people that we are trying to focus on now to find a strategy on how to reach them. So among the strategy, the one that I have put forward so far, and some of it we have been implementing, For example, like we have been sharing the Safety Gene expert among the resource limiting public, the primary healthcare center in the remote area in order to reach out our people who inject drug. And in one of the center, 80% of the healthcare of the hepatitis C infected people who inject drug receive the same day treatment. So this is very good. I mean, in order to cut down all the visits and also make it easier for the patient as well as for the healthcare provider. The next one, which is very exciting, and I'm very excited about this, the people who are living in the prison, especially what we have tried before the COVID to treat patients in the prisons with hepatitis C, but somehow when the COVID came in, I think this program has been altered. But we have just started this year recently, whereby the principle of treating the patients in the prisons is mainly to make sure that they all remain in prisons without having to move them in and out from the prisons, because it's going to be logistically and also it's going to be very, very difficult if you want to bring out the patients to get the treatment. So the key principle here is that the inmates remain in the prisons. What have been moved in and out will be the lab tests and the assessments, but the treatments and the patients will remain in the prison. So the treatment will be initiated in the prison itself. So far, it's been doing quite well. We're also with the support staff from our hospital as well, whereby there are some staff who actually go into the prisons and then get the blood for confirmations and come back, and then we will return. I mean, we will send the recommendations for the treatment as well as for the any advice to be given. So this has been doing very well. And the next one, which also is very exciting, is we're trying to get the refugees also to be treated because Malaysia is also a country whereby we house. We have quite a number of refugee camps, and most of our refugees they're not in the camps. I don't think we have refugees in the camp. What happens is quite special in Malaysia, whereby they are in the communities. So there have been effort to treat them as well, and we all know as well. I think among some of the refugees, for example, the Rohingya, there has been reported the high prevalence of the hepatitis C and hepatitis B among them. So we have started to work to treat with them while collaborating with some of the NGOs. And for this particular work, we've been working with the MSF, and we are hopefully, I think by this year itself, I think we have been sharing experience with private training to the MSF so they can start treating the refugees as well in Malaysia. So these are the key elements. What I consider as the main strategy. The first thing is to get the drug available and to get the access by compulsory licensing. We do the treatment decentralizations, going out to get the patients. And then we have what we call the inter-organizational partnership. This is very important as well to make sure that we are working very well, because especially in a country like Malaysia, whereby it's quite resourceful, but at the end of the day, I think we need to be together in order to come up with what we call the effective strategy. Because if there is disagreements or there's something which is need to be settled out very quickly, so that everybody is more or less on the same page in order for us to roll out the treatment and also the test strategy. But above all, I think maybe what I feel the main catalyst in terms of the Hep C/V agenda in Malaysia is because of the very strong political will and also the good leadership at the central level, which coordinating all the work here, particularly getting everybody on board together and try to move forward in a positive manner.
1 minute warning, Dr. Mohammed. Thank you.
Okay. Lastly, I'm also going to just to tell very briefly, I think the other ways of also exploring the options through the R&D, which Malaysia also is investing in this area. And I would like to quote this as two study, which is TOMSI study, and also the EAST ongoing, which is ongoing. What we're doing in the EAST here is that I would like to highlight here is that we shorten the duration from the 12 week to 8 weeks using the generic medication, which is soft-Rabidacil. It's going very well, and it is going to be a very favorable outcome. I think this is going to be a fantastic outcome. I've said that before. Thank you very much for your attention.
Wonderful. Thank you so much, Dr. Razzie. That was, again, wonderful overview of the work that's going on in Malaysia around decentralization. A lot of obviously challenges remaining around reaching some of the more marginalized groups, particularly refugees. I look forward to hearing more going forward as to how you engage with them, and we learn about your engagement with more marginalized groups as well. So thank you once again for a wonderful presentation from Malaysia. I would like to now, we're doing really well for time actually, so this is fantastic to see. So I would like to now move on to our last presentation from Dr. Amarazaya, who is a technical officer for HIV, STI, and TB and hepatitis prevention and control at the Ministry of Health, Mongolia. So really a great privilege for you to join us today, Dr. Amarazaya, and you'll be presenting on the successes and challenges with viral hepatitis elimination in Mongolia. Over to you. Thank you.
Hello, everyone. I will try to talk very shortly, very briefly. I would like to share with you our achievements and challenges with viral hepatitis elimination in Mongolia. In the second half of this past century, the incidence of acute viral hepatitis was high in Mongolia, and the disease was officially registered in 1958. Acute hepatitis B and C was included in the National Notifiable Disease List. The prevalence of the chronic hepatitis B and C is high in Mongolia. And according to the study conducted in 2017, it was estimated that about 10% of the adult population of Mongolia had chronic hepatitis B and 8% had the chronic hepatitis C. Also, the hepatitis B vaccine was fully introduced into immunization program in 1992. Surveillance of fever and jaundice syndrome was introduced in 2015. Based on the health statistics reporting for acute hepatitis are slightly decreasing every last years. Also, you can see that the incidence rate of cirrhosis is high in Mongolia. Also, liver cancer and liver cancer mortality rate in the newly registered carcinoma incidence is very high in Mongolia. The government of Mongolia has taken the measures to reduce the incidence and mortality of cirrhosis and liver cancer. And for the last 30 years, the national strategies and programs have been implemented to reduce and control viral hepatitis. In 2015, the government of Mongolia approved the national strategy to combat viral hepatitis, and the patient society and civil society organizations initiated to upgrade this strategy, and the government approved the Healthy Liver program in 2017. And you can see that the following activities were implemented during this the Healthy Liver program. The Healthy Liver program has been progress, the public-private partnership in healthcare and resource allocation, screening, viral load testing, and DA costs covered by health insurance, which promoted on the reduction of the financial burden for the patients. It also helped to raise public awareness to understand of health insurance benefits. We strengthened the viral load testing capacity at subnational level and made the contracts with private laboratories for viral load testing to decentralize of laboratory service. The involvement of primary health care providers has been increased, and family doctors have been able to monitor their treatment. The Health Libre National Program has been one of the health programs which the largest funding implemented by the government of Mongolia 2016 and 20. Here you can see that under the program, about 1 million people were screened within the 3 years year period. But it was as a result of the screening, it was known that the 8% of the population had chronic B hepatitis and 9% were positive for anti-HCV. In total, the 54,000 people were tested for HPV and 44,000 for the HCV viral testing. Also, since 2016, 8 anti-C antivirus and 6 antivirus B hepatitis virus have been newly registered in the National Medicine Registry Mongolia. DA is delivered for the patients by the health insurance discounts, and 22,000 people have been treated by the hepatitis B, and 29,000 had been initiated for the hepatitis C treatment. After the first phase Health Libre program, that we had, how to say, the WHO, HQ, and VPRO proposed to the Minister of Health Mongolia to participate a pilot assessment to validate the viral hepatitis elimination to evaluate this program results. The proposal to participate this pilot officially submitted in October 2021, and we worked at 2 months with collaboration with WHO. Here, as you can see, that Mongolia has decided to make elimination of both B and C HPV AMTCT. During the pilot assessment, data were collected by the 3 types of tools. This is first is the pre-assessment tool, second the data collection tool, third is the feedback. Pre-assessment tool, we assessed that we did the self-assessment for the current capacity of the elimination. Also, the second one is the collection tool. This is all the indicators collected by the tool. After that, we give it the feedback to the WHO HQ. Here is the impact indicators for NTCT transmission. You can see that the 2 indicators here, and here is the Mongolia's result. The impact indicator was the prevalence of the HBs antigens under 5 children, and also the infants, the proportion of the positive infants born to the positive mothers. You can see here there are the results. Here the vaccination coverage, the birth dose of the hepatitis B vaccination, and timely 3-dose hepatitis coverage also. I want to mention that Mongolia has a very good immunization program, which is all the indicators is we had a very high result. Here is also the other interventions to prevent the MTCT. The program indicators. Here we had the problem with the incomplete data, which is with coverage with the antivirus of HPS positive pregnant women with high viral loads. There is the second elimination indicator, reduction of the HCV transmission and the incidence. Impact indicators, you can see that the annual incidence rate of CV and also annual incidence rate infection among the PWID. The Mongolia has the problem with this PWID incidence because we have no data here. Program indicators are persons with chronic C infection diagnosed. This is the result of the healthy liver program result, and also the treated. We had the problem due to our data collection. It was the incomplete data. Here is the program indicators, and also the impact indicator for reduction mortality. Here is for the impact indicators, annual mortality rate from the hepatocarcinoma, cirrhosis, and chronic liver diseases attributable to the B and C infection. But the Mongolia has no applicable here because we had our statistical data we had collected only by the annual mortality rate due to liver fibrosis and due to hepatocarcinoma, and to register the hepatocarcinoma incidence, but we hadn't registered the attributable to the B and C infection. Here is the impact indicators for the mortality and testing for the B and C infections. Here you can see that the proportion of the persons with chronic B infection diagnosed, proportion of the persons with chronic C infection diagnosed. Here you can see that this is the result of the healthy liver program, which is continued during these years. For the treatment of chronic B and C infections, program indicator was the proportion of the persons with chronic B infection receiving treatment. Here I would like to introduce the issues encountered during the implementation of this program. We had difficulty to compile strategic information to evaluate the implementation of the program. This is because of the data on the population who were involved in the program, healthy liver program. They collected through the 4 separate data platforms, which limited to completion of the data. Due to some typos or incomplete data entry in database, it was not possible to fully estimate treatment outcomes and RNA prevalence. Also, based on the health insurance database, data on the people who were involved in the diagnosis and treatment were collected. It gives only option to include the people whose information is included in the health insurance database. Looking at the implementation of the activities planned under the program, the focus was given to the chronic hepatitis detection, diagnosis, and treatment, and some other activities were missed out. For example, incomplete surveillance and registration for hepatitis B and C attributable conditions, cirrhosis, HCC, and mortality. The Minister of Health Mongolia gratefully received this proposal, and we believe that it gives the opportunity to answer questions where we are, and where we need to go to eliminate the viral hepatitis by 2030. Also, we decided that the Healthy Liver Program, and we currently developing, government has decided to continue Healthy Liver Program, and we are currently developing the new program now. And also, we are thinking what the directions, what kind of the actions we have to take in the next step of the Healthy Liver Program. And I would like to thank to the organizations that supported the implementation of the Mongolian Health Liver Program, especially to the WHO and HQ and VPRO, international organizations, and all our partners who provide the technical support for us. Thank you very much.
Wonderful. Thank you so much, Dr. Marazaya. And it was really wonderful to see the presentation on the validation work, which, you know, for us, it's been an amazing, really important work for sort of the development of the guidelines for validation for elimination. So thank you so much. And I'm pleased to see that it's also contributed to, you know, strengthening the strategic information in Mongolia. So that brings us to the end of the presentations. Thank you so much, everyone. Really incredible presentations. We'd like to now move on to the final bit of the session, which is a panel discussion. So essentially, you know, just having a Q&A. We do have some questions, I believe, Ben, in the Q&A box. So over to you, Ben.
Thank you, Sahar. And look, really very keen to make this as interactive and as dynamic as the presentations have all been. But I might start with a couple of the questions that were posed to Dr. Ailing. So the first question was, what is the key major issue for China moving on and finishing that sort of last stretch, that last mile of prevention of mother-to-child transmission of hepatitis B? What's the big last step that China, you feel, needs to take? I think you may be on mute, Ailing. My apologies.
For the last mile of implementation is for us, for the, I think it's maybe the, how to say, the use of the ARVs, the time of use ARV, because several pregnant women with HIV, they couldn't come to antenatal care at the first or second trimester. Maybe that they come to at the third trimester. Is how to say, it's not earlier come to hospital. So maybe they just they can use the ARV drugs just at the laboratory. So it's we try our best for use some participant, community participant, or use how to the CBO to help us to ask them, find them to as soon as earlier as their antenatal care this year, in these 2 years.
Yeah, great, thank you, and such important considerations. I might now, I'll come back to you in a moment, Aileen, because there's another question for you. But before we get to that, I'm going to bring forward the question to you, Dr. Mohammed, that's in the chat. So did you how did you train, this is a question from Dan Saltman, how did you train the frontline providers to test, prescribe, and monitor the treatment with direct-acting antivirals? Do you use standing orders, or are there standard guidelines for the frontline healthcare workers to follow to enable that sort of scale up?
Oh, thank you very much. Yeah, I think we do have some kind of, well, we do have the CPG, clinical practice guideline, but as you all know, clinical practice guideline is quite like a very brief document. So on top of that, we also have a bit of detail in terms of the clinical algorithms, what they have to do in details. So there's also like a manual of the procedures also being provided. But on top of that, there have been a very regular, what we call this engagements, the virtual, especially the virtual, the echo, and all, whatever the platform that we have, as much as possible that we try to share how best that we can deliver, because every setting have their own way of how to treat. So there has been ongoing engagement from time to time from the trainer to the trainees, and from time to time, and also to the healthcare worker on the ground. Yeah.
Thank you. And I think you just referred there, Dr. Mohammed, to Echo, Project Echo. Is that what
well, this is like an echo form. Yeah, we do also participate to a certain extent in this echo program, but this is part of the overall our continuous medical educations to our people on the ground. So yeah, we do that as well.
Thank you. And so I guess back to you, Ailing, for a moment. So the Dr. Mohammed was talking about treatment scale up, and there's a question here for you regarding whether the PMTCT approach, so whether the momentum that's been gained through your prevention of mother-to-child transmission, whether this is a way of building further treatment programs in China. So do you see that the screening of pregnant women and providing antivirals in pregnancy is part of a foundation for expanding hepatitis B treatment to other priority groups in China?
Okay, because we have from national level, we have updated our technical guideline. Maybe just 3 or 4 years to update one version. Until now, we have 7 versions totally, and we also have the training and every year for on the case to case to case is the TOT trainings. Is we have a different responsibility for us. For national level, we have a technique, the same. We have the same technical guideline, and also have the quality control in our level. But on the provincial level, they have to the training, and they have own adopt our technical guideline, and have their pay attention on their responsibility to the quality control. So for us, we want to pay more attention on the quality control to do the similar quality of the service. For ARV, for screening, for the follow-up, we have many times control to do the for the hospitals. I think is the main point for us to know the to have the similar quality.
Yeah, and so if I could just explore that a little bit further. So if a woman who is pregnant receives antivirals because of a high viral load, what is the approach to testing and linkage to care of her household members, of family members? Is that part of the program? Is it like, does it move beyond the prevention of mother-to-child transmission into broader testing and treatment of family and other contacts?
Because the antenatal care rate in China is very high. It's almost 99% to pregnant women to get antenatal care rate. Almost every people, when I am pregnant, I of course go to hospital to do the antenatal care. So they have a chance to get the HIV, syphilis, and hepatitis B testing. The screening is until now, last year, the screening rate is 99.9% for almost every pregnant get screening. If I am HIV positive, some hospital will be we have a focal point in one hospital, just one focal point to connect with the positive pregnant women and guide them and to give the following service for them. And they also, their husband also get the HIV or syphilis testing for the couple test, and is also free. It's for them to know their HIV or syphilis status. So it's can keep the secrets in their families and know just the couples to know their status. And just a few health provider to give the service, not to spend too much not to the other doctor or nurse to know their status. So they can have they understand more each other very, very well.
Thank you. And we're very lucky that in this panel, we've got two representatives of ministries of health in our region, obviously Malaysia and Mongolia. I'd like to turn to Amazaya. The Healthy Liver program in Mongolia was really one of the most comprehensive and substantial integrated responses to viral hepatitis in our region, and is something that was obviously the result of huge political commitment and financial commitment in Mongolia. So my question, I've got two questions actually. First of all, you've presented a lot of data there, and the data that you've presented are incredibly detailed. So how are you planning to continue to resource data collection in Mongolia around the hepatitis response? And then secondly, how do countries sustain that sort of level of investment with so many other challenges in place and so many other priorities, not just during COVID, but following? So two questions: ongoing data collection, but secondly, more broadly, how do we continue to fund the hepatitis response in countries like Mongolia?
Okay, thank you. Good afternoon, good morning all. On behalf of the Minister of Health, let me respond. I am Dr. Anu from the WHO Country Office, and we are in the same consensus. Thank you, Ben, for very important questions. And for the first question is, the main findings of the evaluation of the last 4 years of the program, our national program on communicable disease prevention and control in 2018 to 21, as well as the findings which comes from the piloting of the validation of the elimination of the viral hepatitis. There is a major concerns and challenges that should be addressed in the future is the data. data and also the data analysis, data reporting, compilation, consolidation, and analysis in terms of the all indicators including the impact, progress indicators. That will be the more evidence for the towards the reaching the SDG goals. And right now, these all the findings, especially the strengthening the data reporting, analysis, and surveillance, will be included in the next planning strategy of the action plan for the 2020 to 24, which is under the progress of development by the Minister of Health. In the second question, we would like to respond that again, the measure, the focus area, priority area is the sustaining of the all success and achievement that gained after the implementation of this our national viral hepatitis response measures, and the sustainability, ensuring the sustainability of the funding is very important, and it will be included as the next planning. As again, I would say here that as Dr. Marcel also presented in our overview in the first pre-summit, the workshop of the World Health Hepatitis, the summit, as the Mongolia is moving forward to continue the phase 2 of the health delivery program, and it will be again the some sustainability in terms of the funding will be ensured and planned. This over to you. Thank you. Yeah, and also the within the health delivery program, as Dr. Amasai mentioned, that the main very strong platform that moving forward the health delivery program success for the implementation was the health insurance the mechanism, and it will be also continued. That will ensure the more sustainability of the funding. Over to you. Thank you.
Thank you so much. Such important considerations, and thank you for those responses. I'd like to bring Dr. Mohammed in again from a Ministry of Health perspective. We have a question from Hanyang Chung. The upscaling of treatment in Mongolia, does the upscaling of treatment increase the financial burden to Malaysia in the elimination journey? I think the real thrust of this question is how much more resources and financing are required to increase uptake of hepatitis C treatment. But if I could, is this an investment that is then returned in other, not just aspects of healthcare costs, but in the broader societal costs? So the cost of upscaling treatment, but how you made the investment case within your country.
Okay, we'll try to answer that. There was one study done by one of our colleague, Chand, who did a study on the cost effectiveness on hepatitis C currently done in Malaysia. So what he did was he compared the allocations of the allocations for the treatment of hepatitis C prior to the compulsory licensing, and also after the compulsory licensing, after we have escalated the number of the treatment. What he found was very interesting, in the sense that the amount that had been invested still about the same, but yet we can treat a lot more. So in other words, it's going to be very, very cost effective, in other words. So with all the strategy, with the innovations, and also with the competitions that we have right now, the cost of the drugs is coming down, a lot, and also in terms of the laboratory support also has reduced tremendously. So I think all in all, it doesn't incur so much of the extra cost when we are about to when we are escalating the number of patients to be treated. So I think that's probably the best that I can try to respond to your question, Ben.
I was muted, sorry. That's great, Dr. Mohammed. That's a fantastic answer to the question. And these are vexed issues, and they're things that every country in our region and indeed globally faces as we all proceed down the road to hepatitis elimination as agreed by all member states. I note that we're getting close to time, and I really don't want Sahar to be angry with me, but before we do finish, I did want to give an opportunity for this last question, and I'd like to pose this to both Chris from a perspective from the Philippines, and then to Leanne from the perspective of the region and the World Hepatitis Alliance. So Chris, there's a question about, given the high liver cancer due to viral hepatitis in our region, and particularly I'd like to ask about the Philippines to you in the first instance, how in the Philippines are you working with Non-Communicable Disease Alliance and I guess cancer civil society organizations to align the hepatitis civil society response to the cancer civil society response? So from you regarding the Philippines, thank you, Chris.
Okay, because we are lucky because just last year or 2 years ago, I think we passed the cancer control bill. So the cancer control bill will represent all different kinds of cancer, colon cancer, liver cancer, you know. So we are also part of the PWG of technical working group of the cancer group. So what we want to do now, since prevention is also an aspect of the liver cancer, right? So what we want to do is to be able to merge two groups, the technical working group from the hepatitis B and the technical working group from the cancer, liver cancer group. So once we were able to merge, so it will address the problem starting from the maternal to child, then to the adolescent, and to the middle ages. So middle stage. So that is one way that we will be able to prevent liver cancer and also at the same time to get those treated. Back to you, Ben.
Thank you so much, Chris. So same question to you, Leanne. From the perspective of the World Hepatitis Alliance, how are you approaching with the NCD, approaches to cancer prevention and integrating the civil society messages between cancer and hepatitis?
Thank you very much, Ben. I guess to answer the question, I would like to say two things. So one thing is to answer that directly, that's about the NCD Alliance and NCD in general. So actually what WHA has been doing is that, so we have not done as much as we wanted on that space. So what happened was that we have worked before with the NCD Alliance before on a UHC webinar, but we would love to work more. And then on another note, in terms of like integration with NCD and cancer prevention, so if like for people who attended the session yesterday, the panel discussion yesterday, so we had Carrie from UICC. I need to try to call out their names correctly. What are they? So they are cancer people, and yeah, from the session yesterday, and then we also like met again at the conference dinner. So it looks like we'll be working a lot more with UICC as like in cancer prevention for hepatitis B and C.
Thanks, and thanks so much, Leanne. It's such an important issue, and I think being able to harness the advocacy and the recognition of cancer as a priority and allowing that to inform our hepatitis responses in our countries, in our region and globally is so important. So that's really good work, and thank you for sharing it with us. I can see in one of the multiple streams of information coming into me right now, some of our panelists have got some questions for each other. I know we're at time, but we're going to devote a little bit of time. So, Chris, you were asking a question regarding countries of funding diagnostic tests. And then I think, Thomas, you've fed in that this is a really important issue for Kiribati as well. So Chris, do you want to sort of flesh out your question briefly, and then I'll go to Thomas and then take other panelists' viewpoints on this question?
Well, actually, if we notice in our country, the cost of medication for Hep B is very small compared to the diagnostic. So you wouldn't get to treatment without getting the diagnostic. So I was wondering, even for Hep C, the cost of diagnostic is very expensive. So does the funding compete between the medicine and the diagnostic? Is within the same pool? How do they do that? Or different funding for diagnostic, different funding for treatment?
Yeah, thank you, Chris. And I think you had some perspectives on this question, Thomas.
No, thank you. Yes, it is quite it's a pertinent question right at this moment for Kiribati, because as we've initially, since 2018, the initial 3 years, Gilead was generous enough to offer free medications year-round for our patients. And as we've scaled up and that 3 years has lapsed, we realized that now we're contending with looking for suppliers with cheap medication. So at the moment, we've sort of secured some offer for $6 a bottle for tenofovir alafenamide, and there's $4 a bottle for tenofovir TDF. And so we're looking at potential affordable ones. And as we start to increase with a prevalence rate of about 15% for the country, we can't afford to treat everyone. And with a test and treat approach, it definitely is going to be a big cost to the government, which cannot afford it with other communicable diseases that are very much prevalent, like TB. And so it becomes a bit of a challenge, a big challenge on how we're going to manage. Are we going to modify the treatment guidelines and really pin out who needs treatment, who can afford treatment? And so it's I don't have the answers at the moment, but it's definitely something that's on our mind.
Well, Thomas, thank you. And you may not have all the answers right here, but your presentation showed just the innovation and the huge commitment that's being showed by yourself and your colleagues in Kiribati to addressing this question. And if I might then sort of broaden it out, I mean, we've had presentations today from colleagues from Kiribati, from the Philippines, from China, from Mongolia, from Malaysia. We've had inputs from Australia, and obviously from our WHO colleagues there in the Western Pacific Regional Office. We've had inputs from people from the USA and from the Southeast Asian region. What a fabulous session. I think for me, the real commitment and the strong themes coming through all the presentations of honestly facing the barriers that are in the path to elimination and systematically addressing those, whether it's distribution mechanisms, whether it's the price of drugs and issuing compulsory licenses. The importance of decentralization, strongly referenced by our colleagues from Mongolia, about the need to shift the care of people living with hepatitis away from big institutions and reference hospitals in capital cities into the communities where people live, and to integrate it in the universal health coverage perspective with all of their care, as we increasingly embrace that philosophy globally. The need for a strong, sustainable program, such as the PMTCT program in China, and just how important it is to have good mechanisms in place and that sustainability to ensure that whatever we put in place endures on the path to elimination. And I think some of the examples from our colleagues in Mongolia about how critical good data are, bringing in the themes of operational research, which I know is close to Sahar's heart, that this is essential to guide implementation and to allow us to identify new challenges and opportunities. But if I may, in closing, before I hand back to Sahar to close the session, I think we've had a really strong indication from all the speakers, but particularly from Chris and Leanne about the importance of civil society, and of the voice of people living with viral hepatitis. That it is not just about consulting with affected community, that ultimately leadership of the response rests with people living with viral hepatitis, and that they need to be included, not just as a reference group, but actually teaching us what needs to happen programmatically, clinically, and from a policy environment in all aspects of the response. And I think that came through very strongly. So I think we've got a 5-minute video at the end of this session, but before I do close, or before we get to the video, I'd like to hand over to Sahar, my esteemed co-chair, to close the session. Thank you.
Thank you so much, Ben. I could not have done it better myself. Made really great closing remarks, and I really don't want to say anything further to that other than saying thank you so much to everybody for your wonderful presentations, your engagement, the discussions, really thought-provoking, and I look forward to working with you all going forward. And yeah, I'm hoping we do get to that elimination target that we're waiting for before 2030. And once again, thanks so much for everybody online for your generous contributions with questions. Really great discussions. And with that, I wish you a very great night. If it is night for some of us, some of you day. Thank you so much and take care. Bye-bye.
The doctor told me that, look, you have hepatitis B, so you cannot go overseas. No one at all from my village had that opportunity to go overseas for study. And for sure, my parents would not be able to afford any of that. So having a scholarship to study overseas is actually a really big deal for someone from a village in the north of Vietnam. And I was lucky enough to secure a scholarship to study in Europe. And as a part of the paperwork, I have to go through a health check, and hepatitis B test is among the health check. So when I came to get the result, the doctor told me that, look, you have hepatitis B, so you cannot go overseas. And then I had to reject the scholarship just because he told me so. I don't know why, by that time I didn't challenge him or explore more, whether what he said was correct. But look, as a first year university student, and you had no experience in life, and then you tend to trust everyone that deemed to be more superior than you, like the doctor in the hospital.
In the time it takes to watch this 30-second video, someone will lose their life to hepatitis. It could be your parent, your partner, your child. It could be you. But it doesn't have to be this way. There is a cure for hepatitis C, a vaccine and effective treatment for hepatitis B. We have the power to eliminate hepatitis and save 1.1 million lives each year. It's time to act. Hepatitis can't wait.
Hoy es un día muy esperado para todos los integrantes de la Asociación Buena Vida, porque celebramos la cura de varios pacientes de hepatitis C. Nosotros En nuestro grupo decimos que vivir con el virus de hepatitis C es sentir que uno tiene una bomba de tiempo dentro de uno y que no sabe cuándo va a explotar. La cura significa desactivar esa bomba. Por eso estamos todos juntos hoy para festejarlo, entregar las remeras con la inscripción de hepatitis C curado, y ese es el momento cúlmine de nuestra labor como voluntarios de la Asociación Buena Vida.
Soy Raúl y estoy curado.
Soy Majo, estoy curada.
Soy González Julio y estoy curado.
Hola, soy Susana y estoy curada.
Soy José Luis y estoy curado.
Soy Graciela y estoy curada.
Soy Adrián y estoy curado.
Soy Andrés y estoy curado.
Hola, soy Miguel y estoy curado.
Hola, soy Gabriel y estoy curado.
Soy Carlos y estoy curado.
Soy Nelly y estoy curada.
Soy Claudio, estoy curado. Soy Rubén y estoy curado.